Welcome to Sound Bites, hosted by registered dietitian nutritionist Melissa Joy Dobbins. Let's delve into the science, the psychology, and the strategies behind good food and nutrition.
Hey everybody, thanks for tuning in. I wanted to let you know that when I interviewed today's guest, Dr. Gabriel Smolarz, I didn't know that I would also be interviewing another guest, Noelle Theodosio, who was featured in the last episode. I decided to make this a two-part series to address the science and social science, or culture, of obesity, with a goal of changing how we see, prevent, and treat obesity by helping people with obesity see their weight and weight management differently, and helping physicians and other healthcare professionals gain a more robust understanding of obesity and talk with their patients differently about obesity. So last week's episode is part 1 and focuses on insights from social sciences to help move the obesity conversation forward and improve obesity care. Today's episode, part 2, focuses more on the science and the clinical or healthcare aspects of obesity, such as the brain's role in appetite control and regulating food intake, metabolic adaptations related to obesity, treatment options, and other considerations for improving outcomes. I encourage you to listen to both episodes as they complement each other very well, but you don't have to listen to them in any particular order. Either way, I hope you enjoy today's show. If you are a healthcare professional looking for a fun way to get your continuing education credits, be sure to check out my free CEU library for registered dietitians, dietetic technicians, and certified diabetes care and education specialists. As always, reach out to me anytime on social media. I'm at Melissa Joy RD on Twitter and Instagram, or email me melissa@soundbitesrd.com with feedback, questions, or ideas for future topics or guests. And if you like what you're hearing on the show, let me know and share it out on social or with your colleagues, friends, and family. Enjoy the show. Hello and welcome back to the Sound Bites podcast. Today's episode is about the science and the culture of obesity. We're going to talk about some key misperceptions and key insights about obesity and how we see, treat, and prevent obesity. My guest today is Dr. Gabriel Smolarz. He is the medical director of obesity for U.S. Medical Affairs at Novo Nordisk. He is a practicing endocrinologist in New Jersey, board certified in obesity medicine, endocrinology, diabetes and metabolism, and internal medicine. Welcome to the show, Dr. Gabe.
Thank you so much for having me. Pleasure to be here.
We first met, I saw you speak at a sponsored conference in Budapest a year ago, January. I think that was like one of my last trips before the pandemic, probably one of yours as well. And then I recently saw you speak at a virtual conference. And so I am just thrilled to bring you on the show to talk about the science and the culture of obesity. But before we jump into this topic, I would love for you to share with our listeners a little bit more about your background.
Sure. Although your introduction really was a concise summary. But yes, so like probably many of your listeners, I wear a number of different hats. I am a medical doctor trained in endocrinology, diabetes and metabolism, internal medicine as well. My main job is as the medical director of obesity at Novo Nordisk in the U.S., headquartered in New Jersey. But I also maintain a clinical practice of general endocrinology and obesity, also here in New Jersey, part-time. And then for my love of teaching, I'm actually also a clinical assistant professor of medicine at Rutgers Robert Wood Johnson Medical School. And I have the pleasure of teaching internal medicine residents all about diabetes, metabolism, obesity, smattering of thyroid, and some other fun things.
Wonderful. Well, you and I connected on the fact that we're both passionate about diabetes. I've been a certified diabetes care and education specialist for 20 years. I love helping people with diabetes, but we also know that overweight and obesity go hand in hand with diabetes. And there's been a lot of talk lately. I think COVID has sort of brought the overweight and obesity topic a little bit more into the spotlight, and we're looking at our health and wellness. And you just really shared some really interesting insights that I want to share with my audience today. So maybe the best place to start would be to kind of talk about what are some of the key misperceptions around obesity? And our conversation is going to be, not just for healthcare professionals and people living with obesity, but how we can kind of come together and change the conversation so that we can really help people. So what would you like to share with us about some of the key misperceptions around obesity?
Sure. Great opportunity to get right to that piece, and very important to me. I mean, these are the 4 key takeaways. One is that losing weight is not just a matter of willpower. It is much more complicated than that. And we know that that's not true based on the biology and the science of obesity, which I'm looking forward to getting into a little bit later. So to recap again, weight loss is not just a matter of willpower. Mm-hmm. The second one is that diet and exercise are the only way to maintain weight loss. That too is a misperception. It's certainly true that lower caloric intake and increasing physical activity are absolutely important, but for some, maybe for many, it's not enough. Mm-hmm. And it forms the foundation, the base of a pyramid, if you will, for the approach to treat obesity. And the notion that there's a few that find success there, that it will work for everybody, that we need to look at a little bit closer. Mm-hmm. The third is that obesity is a sign of personal weakness. And we need to transform the meaning and the depiction of obesity from an emotionally charged symbol of personal weakness or poor character flaws or a weakness of personal strength into really something that's a scientifically defined cardiometabolic disease condition that prevents well-intentioned people struggling to get healthy from achieving the success that they really do deserve. Mm-hmm. And then fourthly, it's that weight is something that you need to manage on your own. And unfortunately, this is something I think a lot of people still believe, but the reality is that there's hope and there's help out there. And there are healthcare professionals like myself and others trained and knowledgeable, and we're getting more and more knowledgeable about obesity that really can help and move the needle there. There's a lot of new things and a lot of new opportunities to help. So you don't have to do it on your own. There's help out there.
Yeah, and that's one of the reasons that I have to admit, I got a little burnt out on working with patients on weight control because it's very challenging. It's daunting. And when I became a diabetes educator, I just felt like there were so many more tools in the toolbox. It wasn't just about weight. It was more about the lifestyle. And as you're talking, I'm just thinking, we would never tell somebody with diabetes, well, diet and exercise, that's all you got. And if you're not succeeding on that, you're doing something wrong. Now there are so many more other tools. And so it's really great to see that with obesity and overweight, we're kind of getting beyond the diet and the exercise. But as we're going to talk today, there's a lot of hearts and minds that we need to educate out there. So one of the things that I just found really interesting was the science that you shared about how the brain regulates our eating and sort of this energy dysregulation. So I would love for you to walk us through that. And I do have some great resources that we're going to share at the end. And one of them is like a flashcard or an infographic that I think will help people. Once you share the science, they can kind of go look at these resources and it'll reinforce what you're sharing. But can you talk to us about how the brain regulates our eating?
Yes, definitely can. And before I do that, I kind of want to level set on the science of obesity, and that, yes, it's certainly complex, but the true understanding of obesity, at least in the clinical sphere, maybe our basic and translational researchers have picked up on this sooner, but it's really only been in like 10 years maybe or so that the clinical world has begun to accept obesity is a disease, like a disease with its own unique pathophysiology, or that there's something going on in the body and that it's thus a disease.
More than just that caloric imbalance.
Yes.
Yeah.
And that's the dogma we've been trained in the last 50 years of the mainstream clinical teaching, is that it's simply an equation of calories in and calories out, and that if you are just net positive, you gain weight, and if you're net negative, you lose weight. But what the disease of obesity, and I'm going to refer to that a number of times, the disease of obesity, are actually something I and a few others refer to as essential obesity, analogous, if you will, to essential hypertension in that sense. But that essential obesity is a disease of energy dysregulation, and it throws off the notion of it's as simple as calories in and calories out. And before I go there, I'm not denying the first law of thermodynamics, which is like energy in equals energy out, and you kind of mass stays the same. Indeed, if at the end of the day, the human body ingests more calories than burned or used, well, then you're net positive and you gain weight. That is true for the most part. There is some funny energy partitioning things that happen that have to do with insulin and the liver and some things along those lines. But in general, it would be true. More calories in, you gain weight if you're net positive at the end of the day. But the question is, the new aha is really about, well, what are the forces at play that determine energy in and energy out?
Mm-hmm.
And that it is not a simple, well, I can just will it. I will just want to do it and it happens. And in fact, the brain controls all of that. And there are some really phenomenal, it's easier to study the stuff in rodents and things like in preclinical non-human models because you can really control things well. But the evidence for this, that the brain controls in and out, is largely indisputed, but not well known. So that is a key piece. And so the disease of obesity is essentially when the body, the brain really, because the brain is the main regulator here, senses that there's not enough energy. And so it needs to promote energy intake in some form or another, and or slowing down or reducing energy outbound. And that's the disease of essential hypertension when applied to blood pressure. So a inherited genetic setting of which the body, and in this case, blood pressure is largely driven at the level of the kidney, that the kidney wants the blood pressure to be 190 over 115 or 130, for example. But we know that's not healthy. And we certainly, as dietitians, nutritionists, and other clinicians said, well, you should lower your salt intake. Certainly, yes, we know that contributes. But what happens if you've made an attempt to lower your salt intake, but your blood pressure still remains 180 over 115? I'd say there's an imbalance here. That's not good. That's a dysregulation of blood pressure. We need to intervene. And that's the disease of essential hypertension. So there's a parallel of the disease of what I call essential obesity, is this setting that's something got funky, if you will. And the body is seeing lower energy than really exists and encourages additional inbound input.
Thank you for explaining that. I was going to ask you about your term, essential obesity.
Yeah, I didn't trademark that. I'm sure there's others using it, but it just I like it because it helps explain the notion that the disease of obesity is not just a failure of willpower, just like familial hyperlipidemia. It's, again, another analogous setting. Basically, you inherited a liver's desirous set point for LDL to be, let's just call it 250 LDL. Say, well, that's not healthy. Why does the liver want it to be 250? And we certainly say, well, reduce your saturated fat intake. We can get into the debate of animal versus non-animal another day, but reduce your saturated fat intake. Okay, so maybe it goes 250 to 240, 230. Well, in familial hyperlipidemia, the liver has a setting of higher LDL. And so we need to intervene, in this case, pharmacologically, most case, in addition to the dietary advice of reducing saturated fat. Now we got to do something else to help the levels of LDL go lower. So it's similar in obesity.
Right.
And so very last thing I'd say about the whole, just to wrap that up, of the disease of obesity, it's that overeating does not cause the disease of obesity. It's the disease of obesity that causes overeating.
It's profound.
Yeah, that's and it flips the whole thing on its head.
Right.
Of what we're talking about, but that's really getting at the disease of obesity.
Thank you. I'm glad you set that stage because it will make more sense now when we talk about how the brain regulates food intake.
Yes. So how does the brain regulate food intake? Okay. So there are signals that come from the GI tract and from, well, it could be the stomach as well. A hormone called ghrelin comes from the stomach. And as you go further down the GI tract, you get into the small and large intestines. And there are actual hormones made in various parts of the intestine that then feed back to the brain to let the brain know what's the status of food and nutrients, energy, calories, etc. It's like in endocrinology, many things are a feedback loop. And so that the master gland, take the thyroid. The thyroid makes thyroid hormone, right? But it's under the control of the pituitary gland through a hormone called TSH. And so as TSH goes to thyroid to tell it to make thyroid hormone, well, that thyroid hormone feeds back to the pituitary to say, okay, good, you listened, and you've made thyroid hormone, thyroid, very good. So it's a feedback loop, and there are many loops and feedback loops in endocrinology. So energy and nutrition intake is very similar in that regard, in that how does the brain know that, hey, we've just taken in energy? And so these hormones from the intestines, of which there are several, and I'll go over some of those, are relatively a short-term regulator of energy intake. So let me do part one of these hormones here. So ghrelin is a hormone that comes from the stomach. And I help my students and my patients remember ghrelin is like the little gremlin in your stomach that's growling when you're hungry, right? And it's a potent hunger hormone. And it goes to the hypothalamus. And that's really where the main action is happening. There may be other parts of the brain involved. There likely are other parts of the brain involved. But it's largely understood and believed. Most of the action is happening at the level of the hypothalamus, which happens to be among the most primitive, basic parts of the brain, like the survival part of the brain. That's ghrelin. Then there are other hormones that are examples like insulin and amylin, because those are secreted when we eat, right, to help handle the carbohydrates in the food. There's also GIP, there's PYY, there's GLP-1, and a couple of others that are all part of the hormonal milieu that creates a cascade of feedback to the hypothalamus saying, okay, good, we receive this energy. And what it normally does in a normal physiologic situation is then those signals would then go back. Hypothalamus would receive this input and say, okay, well, we can slow things down now. We don't need to be in hyperspace mode, if you will, for eating. And so we can slow down. And these hormones, of course, have other digestive effects that promote the handling and the removal of the calories. Just like we all know, insulin is the hormone that tucks away the glucose that's in the blood into the cells. Okay, so that's one way. And GLP-1 plays a role in saying, hey, liver, no need to make any extra sugar. We just consumed some. So we're good there, and et cetera. So there's a number of these that all contribute to that. So there's a part of all of that action happening at the level of in the digestive tract, but also at the level of the brain, inducing what's called satiety and feeling full and meal termination. These are all like elements of what's called ingestive behavior. So it's fascinating and really complicated of, when to stop eating, when to slow down, when you are interested in food, when do you feel full, are you hungry, are you less hungry? So to just go back a little bit, so ghrelin is the one that goes to the hypothalamus to say, eat, we're hungry, and largely induced when the stomach is small and kind of shriveled up is sort of the image I propose to keep that in your memory. And when the stomach expands, that actually turns off the ghrelin. And then the ones I mentioned after, are the ones that basically contribute to meal termination, feeling full, no longer hungry, satiety. Those are the shorter term ones. Then there's this other guy called leptin. And leptin is not made in the GI tract. Leptin is made by adipose tissue, our fat storage cells. Although fat tissue, adipose tissue, is also metabolically active in a number of ways too. But so the notion that fat cells are simply just the storage tanks of energy is a myth, because it's not true. It does more than that. And leptin is kind of like the long-term barometer to the hypothalamus in the brain of how much energy is around. It's considered a long-term regulator of appetite. And so there are diseases in which leptin receptors don't work or don't exist. And therefore, their body doesn't see the leptin that may or may not be there, and that causes problems. But with the disease of obesity, there's a notion that the body is not really processing the leptin that's around, that someone with a BMI, let's say, of 35 that has excess weight, excess adiposity, even more specifically, their leptin levels should be high. They actually usually are high. And that normally, under normal circumstances, that would indicate to the brain, if everything is working properly, hey, the gas tank is full, so we should not be in hunger mode. But with the disease of obesity, it's not. It's as if the tank is empty, and that leptin is not communicating. I mean, we don't know, is it the leptin's fault? Is it the brain's fault, the receptor fault? That's a little bit maybe beyond the scope here, but the essence is leptin is or should be high, but the end result is not what we would expect. It's not working. It's almost like there's, not almost, but some people refer to it as leptin resistance, in that the leptin is there, but why isn't it causing satiety? Why isn't it indicating gas tank is full, that we shouldn't constantly be in almost survival, hibernation, eat mode, conserve calories, eat more if you can, kind of in that mode. That's the fundamentals of the disease. And that's not will. You can't will that away.
Right.
That's not under voluntary control. So that's why the main message here, if there's like one thing that I'd love your listeners to take away, would be that, again, the disease of obesity is not one of willpower, that there's these other hormonal things going on that control whether one eats or doesn't eat, feels full, doesn't feel full, seeks food, doesn't seek food.
Yeah, when you said leptin resistance, I was thinking, like insulin resistance.
Yeah.
Like you said, whether it's not detected or the body's not sensing it or, whatever's going on there physiologically. But that's very interesting.
Yeah.
I love all the science. This is great. And it just speaks to the complexity and all the hormones involved in all the different aspects. And I'm sure that's just scratching the surface. Like diabetes, it's also very complex. And there's so many different organs involved. And now there's all these different medications that work on different organs and work in different ways because, I don't know, there's like 11 or 12 different, whether it's the brain, the gut, the skeletal muscles, the liver, there's all these different things going on. Great. So let's talk about these 3 different ways. You have some terms to share with us about different types of eating for hunger, eating for pleasure, and deciding to eat. There's 3 different categories, and also it looks like there's 3 different parts of the brain that I'd love for you to talk about.
Yeah. So what this is getting at is, again, the complexity of appetite regulation and who are the main players in the brain and the different parts of the brain. And so think of it kind of like we have our very primitive brain, the part of the brain that is charged with survival. Like if you hold your breath too long, well, then carbon dioxide levels build up in your blood, oxygen levels go down. This sets off a cascade of emergency signals happening in your system. And even if you were to try to hold your breath for the 10 minutes, it's not going to work because primitive brain picks up on these things that are happening and says, oh no, and induces the body to take a breath. That's an example I like to give because it parallels this notion of, well, we just need to eat more salad. But if your primitive brain is getting a signal of starvation, there's no amount of, well, I'm over my calories today, so I'm just not going to do it. Your primitive brain is sending really strong signals of not feeling full and of hunger. And primitive brain is very powerful, very potent. As you can imagine, because it's the fight or flight, it's the survival part, it's the caveman brain of monitoring the most basic elements of survival. And so we call that actually the homeostatic part of the brain. And homeostasis refers to the state of balance in and out. And so it's trying to achieve balance in sugar, balance in carbon dioxide, oxygen levels, balance in energy, balance in probably a bunch of other things as well. But it's all about basically chemical balance of the brain and the body.
Okay.
Then the next part is the hedonic part of the brain. Eating because it makes you feel good, or maybe it's making you feel good for some reason or another. And whether that is eating out of boredom, that's a possibility. Eating out of stress, because then eating can make certain people feel good in that regard. Eating with a history of perhaps trauma of some kind. There's a whole host of subcategories that would fall under the hedonic part. That's the part of the brain where it's the end of Thanksgiving dinner and you already had dessert. And then, somebody arrived late to the party, but they brought this delicious dessert. And you're like, I just ate all this, but wow, that looks phenomenal. And they're sitting down. And then there's a social element to it where you just picture it. They're taking their coat off. They're sitting down at the table. Someone says, here's a plate. You're opening their dessert. And you're like, sure, I'll sit and I'll eat with you. And that's almost like the socialization layer of all of this mixes in there. But also the dessert looks so good and it smells so good. And, maybe the dessert they brought remind you of grandma back in the day. And it just it's just that whole food, joy, pleasure, even though your homeostatic part is totally content. It's like, nope, we're done. We're full. Not interested. Had no intention of consuming more. But the pleasure, which is very powerful too, as we all know, can alter behavior. So then that takes us to the third part of your brain, and that's the part you can control, or you think you can control, your executive function, your planning part, your, I just got to learn more about this. If I'm only just more aware, whether it's I'm going to get educated on types of food, I'm going to track my calories, I'm going to track my steps, I'm going to learn about X, Y, and Z. Again, that's foundational. You don't take that for granted. That's good to know in certain elements there. But it's very hard for that to supersede the homeostatic and quite often the hedonic part of eating. And so it's almost like when you're counting your calories, for example, that's very helpful when your internal calorie counter is broken. Well, yeah, counting your calories is a very good thing to do. It's kind of like I have patients with attention disorders. Okay, so what do? You write lists, or you use your executive brain. You set reminders on your phone, or you do things to help. I left my key. You use technology, like I have this cool little thing that tracks keys. You could attach it to your keys, so you never lose your keys. Tips and tricks like that, so you don't misplace things. That's using your executive brain for helping your homeostatic or hedonic brain. I'm making some generalized examples here to kind of tell the story here, but that's the idea. Said differently, I have this car that the gas gauge is broken. It's literally broken. It's a 25-year-old car. So what I do is I fill up once and I track my miles on the odometer. That's how I know how far I have on my full tank of gas. Tracking calories with a calorie counter type of thing, whether it's an app or whatever, is kind of similar, right? You're like setting out, I have a certain calorie target. This will help me get close to that target, because without doing that, I have no idea where I'm at. That's good. That's very helpful. But what if that light on the front dashboard was always yellow and it's always on empty? And actually you had a car that starts yelling at you saying, you better pull over. In fact, I have a different car that says, oh yeah, we're near empty. Do you want to find a gas station now? How about now? And I delay, and it comes back on. It's like, how about now? So, and that's the homeostatic brain saying, hey, time to eat. And you're like, no, I should be good. That's the disease of obesity. It's not a failure of willpower. It's not a character flaw. And as you mentioned early on, you got frustrated with your patients, what are you going to do? Well, the problem is a deep-seated electrical wiring problem. It's not if only they would track their calories, everything would be okay. Or if only they read the label. Don't they know 2-liter soda is not good for you? Some do and some don't, surprisingly, of course. Just like there are people who, do you know smoking's not good for you? Right? But that doesn't change the needle in everybody of saying, smoking's not good for you. And, oh, good. Okay, thank you for telling me. And now I'm going to stop smoking. There's more going on, right?
Yeah, and I should clarify, I was so frustrated for my patients because I saw how hard they were trying and how little progress they were able to make. And I knew that it wasn't for lack of effort.
Right.
And it was very complex.
Absolutely.
So much going on.
It's literally like, let's just go back to the very kind of non-controversial essential hypertension where, they have a whole long family history of high blood pressure. They don't have renal artery stenosis or hyperaldosteronism, or it's not medication induced. I mean, that's why we call it essential hypertension, is because every time I measure your blood pressure with a BP cuff and it's high, it's not automatically essential hypertension. An astute clinician needs to evaluate the possibility of other causes before calling it essential hypertension, if relevant at the time. Because the treatments are different, right?
Right.
If it's hypertension related to medication, whether it's glucocorticoid or estrogen or another something, then that's going to be the treatment of the high blood pressure. And it's no longer essential hypertension, it's medication-induced hypertension. So interestingly, linking it to obesity, there's different types of obesity, actually. So the fundamental disease of essential obesity is the same of what I said. It's this regulation dysfunction. But there are other causes of obesity. There are indeed monogenetic causes of obesity. There are people who have inherited a genetic problem in which some receptor for one of these hormones or a neurotransmitter or leptin or something along the way that's critical to fundamental physiologic regulation of energy is broken. There's literally a receptor, something that is broken, if you will, due to a genetic issue. That's a monogenetic cause. And some diseases similar to that are Bardet-Biedl, Prader-Willi, and some of these monogenetic causes of obesity. But there's also obesity due to, for instance, medications. There are medications that encourage or kind of rev up the hunger side. And if you take away, substitute, alter those medicines, well, then the balance is sort of returned. And maybe they don't have essential obesity. Maybe it was just hyperphagia due to this medicine that makes you hungry. So, for instance, again, glucocorticoids are a prime example of that. Most people, glucocorticoids over a while induce hunger.
Like steroids?
Yes, steroids. Sorry, yes. Glucocorticoids are a type of steroid.
Like not steroids for bodybuilders, but like steroids for medications.
Yes, I'm sorry. As an endocrinologist, there's glucocorticoids, there's mineralocorticoids like aldosterone. But yes, steroids in general also would include sex hormone steroids. So I'm referring to glucocorticoids like prednisone, hydrocortisone, dexamethasone, etc. Are glucocorticoids. And gluco, because the gluco part, right, your audience may recognize that. Gluco, sugar, right? So if you take glucocorticoids, your sugar goes up as well, or in theory, you can do that. And so there are actually many types of obesity. And where the problem is in any of those three parts of the brain is important to identify so that you can attack it that way. Not attack, maybe not the best word. Address, the problem there. Let's talk about the hedonic brain. Well, maybe there's an underlying mood disorder like depression, anxiety, trauma, PTSD, something along those lines, and that needs addressing.
Is that where the serotonin piece would fit in, or is that more in the homeostatic?
So mixed. So it's not black and white. It's not a nice defined box. Serotonin and norepi, there's receptors for that kind of all over. And so then it's like, what are the neural networks that respond to those medicines? And it does cross over. So, but you are correct that there are some of the medicines for obesity that function in that area of the brain, whether it's the norepi, the serotonin, and that. But yes, as you point out, we use those medicines also for certain mood disorders, right? And so there is crossover, and that crossover, now that I've explained these three parts of the brain, should make a little bit of sense, right? Because the hedonics and this homeostatic, and how maybe like dopamine is all over the place, there's crossover. The lines are not so rigidly demarcated in the brain like that.
Right. So as you're talking, I mean, clearly there are a variety of things, some of which we don't even know yet, that can cause or contribute to overweight and obesity. And depending on what the cause or contributions are, would lead us to the proper treatment. You have to fit the treatment to the problem, just like with diabetes.
Yeah.
Again, there's different medications that work in different ways. And if it's not addressing the problem with that particular person, that medication is not going to work for them. So maybe this is a good time to start talking about the treatment of overweight and obesity with regard to medications. And in particular, you talked about all of these different hormones. As a dietitian, I'm familiar with the GLP-1 medications for the treatment of diabetes, but I understand based on your presentation that some of these medications can be used or they've been studied and can be applied to the treatment of obesity.
Yes. And so I want to just jump off the earlier point you made about diabetes. It's really important to know what kind of condition you're dealing with, because we want to tailor treatment to our patient as best we can. Some diseases we can do that really, really well. I do some tests and say, you're going to really respond to this. Oncology is a field where that's really great, where certain cancers, they can do certain receptor testing or gene testing, and they know, this therapy is perfect for that. But let's just go back to the endocrine space. You talked about diabetes. Well, of course, anyone who has, say, a blood sugar of 250, as an endocrinologist, I say, well, what type of hyperglycemia is this? Is this type 2 diabetes? Because that's one type of treatment. But is this type 1 diabetes, of which the treatment will be entirely different than type 2 diabetes? Could it just simply be, for those of you who worked in hospitals, post-acute stress hyperglycemia that doesn't really need any treatment at all, really, and may resolve on its own in due time? Is it a monogenetic type of diabetes? And so I list these just to reemphasize that you really want to match the therapy to the type of condition best you can. Unfortunately, obesity is not yet in a place where we have such a broad menu yet. But fortunately, these medicines seem to work pretty well across the board in general, again, looking at the mean. And will there be outliers on both sides? Always. And just about every intervention, every obesity intervention, weight intervention, has a distribution curve of response. There are those who will respond extraordinarily well to Mediterranean intervention. But if you look at, there's also going to be non-responders to a Mediterranean diet intervention. If we look at metabolic surgeries, there are, again, this is assuming the means are favorable, there will always be people on one side of the curve who responded extremely well, and there are going to be others where it doesn't. This concept of heterogeneity of response, I find personally fascinating, but we need to realize that every intervention, there's this distribution of response. It's just kind of hard to predict exactly who is going to be where on that curve for which intervention. That would be amazing to get to that point. But to get to your latter question, so now that we've established that obesity is a medical disease of dysregulation in general, and now I'm really talking now about you've excluded, there's not an underlying mood disorder, and there's that other, we've done the education, we have encouraged increased physical activity as much as possible. We've encouraged education around food intake and dietary patterns and things like that. And now we're at a point where, okay, there's still excess weight here, and we need to escalate therapy. And again, consistent with the AACE, American Association of Clinical Endocrinology guidelines, or the Obesity Society guidelines, or Endocrine Society guidelines, OMA guidelines, lots of guidelines out there. They generally say, what I'm about to say is, yes, the foundation is increasing physical activity, modifying the diet as best as possible through what we just said moments ago, identifying other lifestyle behaviors that are amenable to improvement, such as sleep. Sleep is really important. It's a prerequisite in my book as well. If you don't sleep well, forget it. You're going to be a mess, right? And so, the whole world about better sleep and sleep hygiene and to get better sleep.
And a lot of that does have to do with hormone dysregulation, right?
Well, it does. People who get more sleep than people who don't get sleep, there is an association, extra weight and cardiometabolic negatives. And whether that has to do with increased cortisol or circadian rhythm issues, it's a bit complicated.
Okay.
It does have to do with the hormones. When we get into, say, something more objective like obstructive sleep apnea, it's a sleep disorder, but there's lots going on there. The treatment there isn't just to say, get more sleep. There you gotta do some more things, although weight loss actually can improve obstructive sleep apnea, but we all know, if it's severe enough, yes, you need a CPAP machine, which then, in addition to helping the oxygenation and the proper gas exchange, it reduces cortisol levels overnight, and that has a whole cascade of beneficial effects as well. So, complicated answer to your question, but sleep nonetheless very important. It's good sleep hygiene and things like that. But then the guidelines would say, after you've done those things and there's still harmful excess weight, then you got to escalate, and that escalation would include pharmacotherapy. Again, I'm going to make the parallel just to drive home the point. Just like in essential hypertension, I still want you to eat less salt if you can, maybe even track your sodium intake. But at the end of the day, if you're trying to do that and you come back and I check that it's still 150, I'm not just going to say the same things over and over again or be like, come back when your blood pressure is better. That's why you're coming to see me. And I'm an outcomes kind of guy. And so I want, regardless of the reason at this point, I want your blood pressure to be down. And so same with obesity.
Yeah, and I just want to put a finer point on it. I love how you're using essential hypertension as your example, and I know I keep throwing diabetes into there because that's what is in my world. But what I love about, and I'm sure it's purposeful, but I want to call it out, is that people with essential hypertension that require medication are not stigmatized or shamed or blamed or like you're doing something wrong. There's something broken. We need to fix it. And that's not what happens with people with diabetes and obesity. There's a lot of stigma and blame and shame. And we're going to circle back to this as we wrap up with some resources and recommendations. But I just wanted to put that out there completely. Like I said, I'm sure it's purposeful that you're using that as an example because you're showing this. Why can't obesity be treated the same way? You
nailed it. It is indeed. And people go to their doctor, their healthcare professional to get, and if they pick up a high blood pressure, it's okay. I'm not blaming you for your high blood pressure. It just is who you are. Once we're able to move away from the blame and the how did you get here and why is it like this right now, which I also don't want to sound like I'm callous about prevention. And that's a whole different topic. And that'll probably be another show given the amount of time we have left and whatnot. Not to discount all of the key things about prevention. But yes, I really am talking, and the focus of our entire interview at this point, I am literally talking about when the house is on fire, we have to do something about the house on fire. Yes, smoke detectors are really important, but I need to call the fire department now and not install smoke detectors.
More smoke detectors, right?
Exactly. That's the shift. And same as maybe my analogy is going to fall through here a little bit, but not blaming on how the fire started. I got to put out the fire.
Right. Great. Well, I kind of interrupted. So we were transitioning into medications for obesity.
Yes. So they largely fall into two broad categories. There's the category of reducing or limiting, inhibiting, preventing the caloric intake through the gut through fat. So it prevents fat absorption, and thereby your calories are less coming in, right? Ultimately, right? You eat a hamburger, and this category of medicine blocks the fat that's been broken down to essentially be absorbed through the gut lining, and you don't absorb, and those calories aren't on your asset tab, if you will, in your asset column, and you basically just excrete it. And that's one way. Now, an astute listener may say, well, how does that have anything to do with the brain? It doesn't. It doesn't affect anything in that whole dysregulation part. It doesn't have anything. It's not working there. And so it doesn't change the leptin issue. It doesn't change the hypothalamus is the primitive brain is receiving hunger signals and moving that forward. So yeah, that one doesn't do that. But it's very effective for some people, and it's not effective for some other people. But the more tools, the better, right? We want more tools. So that's one category. The other category are medicines that essentially work in the brain to induce satiety. They are appetite suppressants. And how they do that, they differ a little bit in their ultimate mechanism of action, but they're fundamentally working at the level of the brain, largely at the level of the hypothalamus. And again, I say largely, there's a little bit of hedging there because it's very hard to study human brains, right? I can't slice and dice those, right? Like we can rodents. And so really good models with rodent models and things to understand pathways and things. And so that's where we say, largely understood to be X, Y, and Z because we're using those other models. But it is, again, it's largely understood that the other category of the medicines work at the level of the brain to induce satiety. How do they really do that? Well, if you think of the hypothalamus has this satiety center. When you get in the door, it induces satiety. The medicines largely work in different ways to get in the door, if you will. One may ring the doorbell. One may knock on the door. One may tap on the glass on the side. One may, something else, use the knocker. And the beauty is the brain has all of these receptors to receive the signal. And some people, the door knocker may be the most effective way. Another one may be tapping on the glass. And that way really gets the attention of the hypothalamus and the part that signals satiety. So again, it's important to take that message home that this other category is working at that level of satiety in the brain. So in no particular order, there's one out there that's a combination of a dopamine and norepinephrine reuptake inhibitor. It's been used as an antidepressant or in smoking cessation, and it's in combination with an opioid receptor antagonist used for opiate conditions. And those two together were studied for weight and weight management, and over the long term showed that, the majority of people achieve a clinically meaningful weight loss, and that's a great tool to have. Another type is one that is a sympathomimetic amine combined with an anti-epileptic drug, and those two molecules knock on the door in different and complementary ways as well to, again, get that hypothalamus satiety center to get stimulated. And then there's another type of medicine, a GLP-1 receptor agonist medicine that has multiple effects. And one of the things it does, in addition to the ways that we know it works or are familiar with it in glucose lowering by reducing glucagon, suppressing glucagon, and slowing gastric emptying, and with a net glycemic benefit, GLP-1 also hits that satiety center in the hypothalamus as well. I've lost my analogy whether this one now is the door knocker or the doorbell or something like that, but it's yet another one of those with the ultimate goal of getting in that center. And those are the GLP-1 receptor agonist class of medicine as well. And it's great to have a toolkit, an ever-expanding toolkit, because again, this heterogeneity of response, it's hard to predict who will respond how. And then there are reasons, maybe I'll use this one in this patient type, hit two birds with one stone, perhaps, or there's a contraindication to something, or just the mean weight loss seems to be better and there's no reason not to start this particular one. But I wish there was like a, ABC, just go down the list kind of thing. We're not at that point yet, but we are at the point where there are options. And that's the key takeaway, that there are options. And we just need to strap the tool belt on. And been watching a lot of Star Wars, in case you can tell. Start using your tools and get the results and give it a try in the right patient, of course, who doesn't have, for the right individual.
Yeah. So you mentioned the fat blocker one, which I know that's been around for a long time. And then this complicated combination sounds like it's been around for a long time.
Yep.
But the GLP-1, that's a newer one for me. Like I said, I keep bringing diabetes into the conversation, but there are a lot of diabetes experts who believe that GLP-1 agonists should be first-line therapy in diabetes. And some of the effects is that it kind of mimics like small frequent meals. It helps slow down the GI tract. That's from a diabetes standpoint. Is it those sort of effects that make it helpful? I mean, because we're talking about the disease of obesity causes overeating, and we went through all of these different ways that the brain regulates our eating and our hunger. So is it these types of effects that the GLP-1 has that can just kind of calm that hunger and that constant thinking about food that some patients struggle with?
Right. Yes. So part one, there are GLP-1 receptors in the brain. And again, to go back to an earlier part of our conversation, that makes sense. That is one of the hormones that are released by the body in the intestines after meals. And so that's how it normally goes up to the brain, says, we just ate, we can slow down. And so using that concept pharmacologically, we are then able to induce meal termination, feeling done with food, fullness, satiety, by giving a GLP-1 receptor agonist. And that then will work up in the brain, similarly like endogenous GLP-1 or the body's homemade GLP-1, and do the things that it normally would do when everything would otherwise be working normally. So GLP-1s do make sense in that regard. Again, it's that hormone that the body's making that already plays a part of all of that. Yes, in diabetes, it's known GLP-1, endogenous GLP-1, and hence GLP-1 receptor agonists are known to, again, slow down gastric emptying, to induce a slower delivery of nutrients to the absorption part of the intestines, and also, importantly, suppresses glucagon, which is a big reason of postprandial hyperglycemia and fasting hyperglycemia too, in that regard. But it also does have that central nervous system effect, that getting to the brain and inducing satiety up at the level of the hypothalamus. And so, yes, by giving GLP-1s for looking at chronic weight management, now you're leveraging that element, that satiety-inducing element up at the level of the brain. Mm-hmm. That's where it's used. And then the various studies and experiments are designed in different ways to demonstrate different things. And so if you want to show that this intervention helps with chronic weight management, well, then you study weight as your main endpoint, if you will. And that's what some of the newer GLP-1 medicines have aimed to do. So the overall mean efficacy, we can look at that. And it turns out that of the medicines I've mentioned and that are around, these medicines do indeed collectively induce a clinically meaningful reduction in weight for a meaningful amount of time as well. And so we know that a 5 to 15% weight loss, more if you can, is clinically meaningful. It reduces triglycerides. It reduces systolic blood pressure. I mean, there's a whole other topic. What are all the things that happen? Mm-hmm. A lot of different things happen. And with greater weight loss, with greater magnitude of weight loss, you also get different benefits as well. So triglycerides and glycemia are some of the earlier things. And then things like removal of fat from the liver, steatosis and things like that, maybe take a little bit more weight. Improvements in physical functioning, maybe take a little bit more. Because there's also quality of life issues with excess weight. The ability to, simply play basketball, go for a run, or maybe even tie your shoes, or just be on the ground, playing with the kids sometimes are things I hear a lot from my patients. And so those things, different amounts of weight loss can help with those things overall.
I'm glad you mentioned that, because I was going to have you define this clinically meaningful weight loss. And I think that speaks to, most healthcare professionals know that it doesn't take much weight loss to make some of these improvements in outcomes.
Right.
But the average person who is overweight or obese, I don't think they know this. And I think it also conflicts with what they think they would want to lose or they think they should lose. So as we're kind of wrapping back around to where we started with the science and the culture of obesity, I'd love to talk about, how we can change the obesity conversation. We want patients and people to see their weight and their weight management differently. But we also want health professionals to talk about it differently and to maybe to see it differently themselves. So I know you've got some great resources that I'll put in my show notes at soundbitesrd.com. But in wrapping up, let's talk about that, the culture, the stigma, how we can change this conversation.
Yeah, definitely. So getting people with excess weight and society at large, for that matter, too, to think about their weight differently is absolutely key. It's partly because of the bias and the stigma that accompany the disease, and many are conditioned by our society to think of obesity as this personal character flaw than the real medical condition. Mm-hmm. And, a lot of what we talked about now, I hope, has helped chip away at that belief of a character flaw as opposed to the true medical condition. It's harder to be biased and stigmatizing when you know that there's an appreciation or a deeper understanding of the actual biologic basis going on here, right? Mm-hmm. And one of the easiest examples of that is, again, I'll go back to the monogenetic types of obesity. Indeed, it was an inherited genetic issue. And that's very much a blameless obesity. I mean, very hard to insert any character flaw notion in, somebody with Prader-Willi, for example. But similarly, I want to move the needle in having people understand that obesity is also a medical condition as well. And 4 out of 10 adults in this country live with obesity, but only a small fraction recognize it. Less than about 4% follow through and pursue any medical treatment as well. I'm sure those are complex reasons behind that, but that's the reality. And so people need to know that there are options for treating obesity beyond just healthy eating and exercise more. Again, not disparaging those, not saying there's a role for those, but again, as I said somewhere in here, I'm an outcomes guy, so I'm focused on the results as well, regardless of the reason. So you're doing A, B, and C, fantastic. Weight's not where we, optimal for your health. We really need to do something else as well. Mm-hmm. That's the overall approach. And then just remember, there's no one size fits all for losing weight. Everybody is different. I mean, we truly are very different. And that's part of why some people respond, while some people don't to certain interventions, why some people can eat a whole pizza and don't gain a pound, and other people can smell a pizza and then they gain 10 pounds, right? Mm-hmm. That's just who they are. Mm-hmm. That's just their genetic and metabolic makeup. And so that's where I would hope we want to get other physicians and other healthcare professionals to talk about obesity differently with patients, be empathetic, be compassionate, understand what's going on, and be a help, not a deterrent, and be knowledgeable about options, because there is hope and there's more that can be done. And we just want to help patients seek out good care, that there are answers, and healthcare providers as well. So to get there, we do have some resources that we've put together here at Novo Nordisk. I've had input on making sure it's pretty good. So your listeners can go to truthaboutweight.com, and that's a great place for basic information, recap a lot what I talked about here, about the science of obesity, the science of weight management, the biology of obesity, why it's difficult to lose weight. Also, why is it hard to, if you do lose, why is it hard to maintain that weight loss? There's a lot going on there. Didn't have time to get into that, but that's something called metabolic adaptation that basically makes it harder to keep that weight down because the primitive survival brain says, oh, no, we're going back up.
Yeah.
So Truth About Weight is a great resource for that big picture and relatively easy to digest information. Pardon the pun there. And then for healthcare professionals as well, there's rethinkobesity.com. And that's just a little bit more nitty gritty on some things and a little bit more clinically focused, if you will, a little bit more about comorbidities and just a couple of different topics there, maybe some more practical things. We talk about the 5 A's, which is an approach to having conversations, and maybe an overview of things to have in your office, perhaps, and things like that.
To facilitate more productive conversations with patients.
Exactly. Yes, a mix of practical and theoretical, I guess. Yeah. Mm-hmm. And yeah, those are really good sites. But again, I'd be remiss not for a shout out to ACE as well, has a really good obesity resource center there.
And I'll put that link in my show notes too.
I mean, again, it's the American Association of Clinical Endocrinology, the Obesity Society, which I think is obesity.org. There's some information there as well. The Endocrine Society is fabulous. All free resources to go ahead and look at as well. So don't want to overwhelm you with
I love putting tons of links in my show notes, and the ones that are easy to share on the show, like truthaboutweight.com, rethinkobesity.com. I have to tell you, those sites are both incredible. I was so impressed with the type of information and the amount of information. They're both really well done. So I really hope people go check those out. And I just think it's so important. I feel like I have this visual in my mind, like you've got people with overweight and obesity on one end, and we've got healthcare professionals on the other end. And I think these resources in this conversation can help bring those two together and bridge the gap there, because both groups need help and support and insight and, like you said, practical tools to facilitate more productive conversations so that we can have better outcomes.
Yes, totally agree. Part of my brain, I don't blame the healthcare community that they just were never taught this stuff. I didn't learn this in medical school. I didn't learn it in my internal medicine residency or even my endocrine fellowship. It was all after the fact. And it's this stuff that we've talked about for the last hour. It's just not part of that main work. That you may not leave medical school without knowing this, right?
Right.
We're not there, unfortunately. It would be great that we get to that point because, again, just about 4 out of 10 American adults have excess weight. And so, again, the World Health Organization was it's the number one non-communicable disease epidemic. There's nothing that has greater prevalence, greater health harm than obesity in the non-communicable category. It dwarfs all the others. Yet it's not a fundamental part of our training any more than, just eat more salad. And I'll see you next time. And so the more people that can understand this, and similarly, like maybe 30 years ago, we didn't quite understand the role of, we didn't understand depression well enough. Maybe it's 40 years. I don't know. I'm making up the number, but what's the role of SSRI if you don't understand that perhaps the disease of depression is a serotonin imbalance or a norepi imbalance? I'm not a neurologist or a psychiatrist, so I'm going to limit my analogy around there. But yeah, like medicines wouldn't make sense. And you just say, well, cheer up. Like you just have a down disposition and you just need more sunlight or something. But that's like, now we learn that this is actually a disease that is largely, and I say largely to caveat me not being an expert on it, largely an imbalance of a neurotransmitter. And if we just maybe rebalance the neurotransmitters a bit, we can help this problem. Not to say don't also do talk therapy, but you may not be ready for talk therapy unless you're biochemically balanced first. So maybe there's some lessons here with obesity.
Absolutely. And just like people with overweight and obesity have great intentions and great effort and they're trying and they want to lose weight, same with healthcare professionals. They want to help people.
Yeah.
So I'm just really encouraged by these resources and these tools that you have, because I do think they're going to be very helpful to both parties.
Fantastic.
Well, thank you so much for coming on the show and talking all the science and culture of obesity with me. It's been a pleasure.
My pleasure. Thank you so much for having me, and maybe we'll chat again in the future.
Definitely. I'll keep in touch.
Thanks.
And for everybody listening, as always, enjoy your food with health in mind. Till next time.
For more information, visit soundbitesrd.com. Music by Dave Burke, produced by Jag in Detroit Podcasts.